this topic, that is the black fungus or pulmonary mucormycosis, is pretty relevant because majority of the states are reporting cases more than their background rate. Some states are having, say, around, say, more than 500 cases currently on treatment. So looking at their experience, we also should be prepared. That is why the state came out with the guidelines. With this introduction, I will straight away go to the topic per se. So the newspapers are full of talk about the black fungus, and they equate it with mucormycosis. But we know it's a misnomer because black fungus is actually refers to the group of fungus with melanin in their cell wall. That is referred to as the black fungus, and that is actually the Phyllophora category. So why mucormycosis is referred to as black fungus is actually from the images which are circulating. That is the patients with the black crust or the scar in their palate over the nasal septum, etc. The cutaneous mucor, you can see the black lesions and all. So morphologically, based on the lesions, you can call mucor as black fungus, but then theoretically, black fungus refers to that category of fungus with melanin in their cell wall. So this is basically the advisory or the technical guideline, you can call that, on diagnosis and treatment of COVID-associated mucormycosis, which was released on 16 May by Kerala government. At that time, the major question asked was, are we seeing enough cases of mucormycosis to warrant the release of a technical guideline on diagnosis and treatment? So the most important aspect is that we have learned the lesson. No, we had the UK strain in wreaking havoc in Europe, and we did not take any precaution. And now the entire country is in the grip of the second wave. So we should not actually be repeating the mistakes. So we are seeing waves of mucormycosis in say Delhi, the Maharashtra, Gujarat, etc. So probably they are maybe around 2 to 3 weeks ahead of us as far as the pandemic curve goes. And so we should be prepared, and we should be expecting a wave of mucormycosis here also. And then even though we say it is a COVID-associated mucormycosis, we know that the most important aspect is the glycemic control. So having said that, as Divya said, previous training sessions had around, say, 500 participants. This session is having only 100 participants because majority of the doctors in the primary care know that they may not be able to take care of mucormycosis once it is diagnosed. But then diagnosing and suspecting mucormycosis is also important. So problem with this thing is the treatment of mucormycosis requires a bit of a skill because the drug itself can kill the patient, that is amphotericin B. So this is basically the classification of fungi, and it belongs to the class Zygomyces. Under that we have the order on Mucorales, and Mucorales again divided into the Rhizopus, Rhizomucor, Mucor, Apophysomyces, and Absidia. And around 70% cases of mucormycosis are due to Rhizopus oryza. And you know that the epidemiological triad is the role of the host, environment, and agent. So what is the host? Who is the susceptible host as far as this mucormycosis goes? It is actually a neutropenic individual or a patient with uncontrolled diabetes mellitus, or a scenario where there is an iron overload state, like in diabetic ketoacidosis and other iron overload state conditions. Then you can have the implantation mucor following trauma. You can have it in burns, in all sorts of immunosuppression, when usually the neutrophil phagocytosis is involved, like in a post-transplant patient, then those on other immunosuppressants, etc., cancer, chemotherapy. This is the ideal host. When we take the case of COVID-associated mucormycosis, we will say uncontrolled diabetes and patients who are being on steroids, tocilizumab, baricitinib, etc. They are the ideal host or a susceptible host. And the agent, we know it's the mucormycosis. It could be Rhizopus or something else. And it is actually the sporangiospores are present in the environment. It's an ubiquitous fungi which is present in the environment. So it is actually rampantly present in the hospital environment as well. And ours is an agrarian society. And probably one of the reasons why mucormycosis incidence is more in Gujarat or somewhere, it could be that it's more of agrarian society compared to Kerala. So having said that, did we have COVID-associated mucormycosis? Actually, we do have that. For example, in Trivandrum Medical College over the last 6 months, we had around 7 cases of COVID-associated mucormycosis. But the problem here is that usually every year, Trivandrum Medical College along with RCC and Srijitra together, we have around 15 to 20 cases of mucormycosis, especially in patients who are immunocompromised and uncontrolled diabetes, etc. So compared to that, last year we have to say that the number of COVID-associated mucormycosis or whatever it be, we had only Majority of the mucormycosis that we had last year was related to COVID. And the number was less than the background rate. And we do have reports from other medical colleges and other private hospitals. So COVID-associated mucormycosis is also here, but we are not seeing it in waves like what is being observed in other states. But we need to be pretty careful about that. So the environment also we have discussed. Does the ICU environment has anything to do with COVID-associated mucormycosis? It's very difficult to say, but we need to be prepared because mucormycosis has also been reported in patients who had mild COVID severity. That is, those who never went into the ICUs or those who never required oxygen therapy, etc. And didn't develop this COVID-associated mucormycosis. So the environment does play a part. But then we need to keep this in mind. Even following a mild mucormycosis, mild COVID-19 infection, the patient is coming with, say, a bloody discharge from the sinus, etc. We need to think about mucormycosis also. So the most important determinant probably is likely to be dysglycemia. So this is actually what happens. How does the sporangiospores get into the body? It is actually through the inhalation, and the second route is through the skin inoculation. That is what you call as the implantation mucor, which we see following trauma or the burns. And once the spores are inhaled, then there is the ideal scenario has to be there. The host should be neutropenic, should be having uncontrolled diabetes, or patient should be on other immunosuppressants, as steroids or tocilizumab or baricitinib. And one scenario which actually favors the growth of the mucor, the hyphal growth, and as well as the hyphal invasion, is the iron overload state. One of the virulence factor is the ability to acquire iron from the serum. We know that in mammalian hosts, usually the iron is bound to the transferrin, lactoferrin, ferritin, etc. So in an acidotic environment like in DK and all, we have more free iron, and the mucor can actually replicate faster in an iron overload state. This is actually very, very important, and this is one of the things we need to look at. Suppose a patient is in DKA, we need to correct this acidosis pretty early so that there is a propensity for dissemination of mucor. We can prevent that. And this hyphae actually can attach to the glucose regulated protein 78 in endothelium and can lead to multiplication as well as dissemination. Now, coming to COVID-associated mucormycosis per se, since the onset of the COVID-19 pandemic, we had multiple reports across country of very high incidence of mucormycosis among patients with COVID-19, especially in those with diabetes and those who have received steroids. And the important aspect of the CAM is that the associated morbidity and mortality. The mortality associated with mucormycosis is around 40 to 80%. And the exorbitant treatment cost. This is actually very, very important. So the backbone of the treatment of mucormycosis happens to be amphotericin. So if you are using amphotericin deoxycholate, so what we call the conventional amphotericin, then it costs only around, say, 300 rupees. But then all the treatment guidelines say that it should be used only when you don't have access to the liposomal amphotericin B. And liposomal amphotericin B, the dose, if there is a CNS involvement, happens to be 10 milligram per kilogram. Otherwise, we need to give around 5 milligram per kilogram. So 50 milligram will cost around 3,000 rupees. So if the patient requires 250 milligram, you can imagine the cost per day. And the duration of treatment, the induction phase may be around, say, 1 month. So you will be looking at, say, around 20,000 rupees per day for a month. So that is a very, very expensive affair. And now we look at the alternative drugs or the drugs that we are using for salivary therapy, like posaconazole or isavuconazole. All these drugs are available in India, luckily as of now. But the cost of treatment per day will be around, say, 10,000 rupees. So the most important thing, what we can do really is to prevent mucormycosis from occurring through aggressive glycemic control. Because if the patient do develop the disease, the outcome is going to be pretty poor and it's going to be an expensive affair. And another aspect that what is being reported from rest of India is a shortage of antifungal drugs. So it is like, we used to have around, say, 15 cases per year. And now some of the states are having, say, the cases being in hundreds. 500 cases means the entire stock of liposomal amphotericin B, the isavuconazole and posaconazole in the country will be sort of exhausted in a matter of weeks. And based on the clinical presentation, the CAM is divided into rhino-orbitocerebral mucormycosis. This is actually the commonest one, that is through the sinus. It extends into the orbit, gets into the eye, into the cavernous sinus, and extends into the skull base, osteomyelitis and meningitis, like that. The second one is the more difficult to diagnose, that is the pulmonary mucormycosis. Third is the gastrointestinal mucormycosis is actually seen in neonates and severely immunocompromised individuals. And the fourth one is the disseminated mucormycosis, where it is a rapid dissemination leading to the multi-organ dysfunction syndrome. It's usually seen in the setting of diabetic ketoacidosis or severe immunosuppression. Here the patient can worsen over days and can die within a week. And the fifth one is the implantation mucormycosis, otherwise referred to as the primary cutaneous mucormycosis. So these are certain examples of how the mucor lesions will appear like. So A is actually implantation mucormycosis following a trauma. You can see that the leg is having that blackish appearance. That is, black is actually necrosis. That is the tissue infarction. It is an angio-invasive fungi and it can lead to the tissue infarction and can appear like the black crust. And the B and C is the classical ROCM, where you can see the palpebral erythema as well as the palpebral edema. You can see the swollen eyes, or one side of the face will be swollen, and you can see the discharge coming from the eyes. And D is the classical sign which we usually see. That is you can see the palatal ulcer. So you can see the hard, dark, the black scar-like lesion over the hard palate. And E is in a neonate. So following the chemotherapy for ALL, you can see the ROCM with skin involvement. So it's having a very, very bad prognosis. The F is in a neutropenic individual following a hematopoietic stem cell transplant. You can see the ischemic or the necrotic lesions or the skin. It is a case of the ROCM, under ROCM. And G is actually a necrotic lesion over the scalp in case of a disseminated mucormycosis. So the take-home message here is that if you're seeing in a patient who has been having COVID-19, diagnosed with COVID-19, so this mucormycosis can occur along with COVID-19 diagnosis, that is referred to as concomitant COVID-19, or it can occur sequentially, that is after discharge, or maybe a weeks later, the patient can present with ROCM. So that is the sequential way in which the patient is present. So any patient who is complaining of, say, dark discharge from the nose, or patient is having such dark lesions, and you ask for the past history of COVID-19, the history of having received steroids, the history of dysglycemia, etc., one of the DDs have to be mucormycosis. So this is one of the articles which came in JAPI around 7 months back. It's from the PD Hinduja Hospital. It's from the frying pan into the fire. This is actually a lot of cases in Maharashtra following the first wave of COVID-19. So this is actually nothing new. So following the first wave, that is in September, October also, following the first wave, they had a lot of cases of mucormycosis. Now we know that the peak in the second wave, the TPR in the second wave is much more than the first wave. And that is why we are having more number of cases of mucormycosis. So diagnosing a case of ROCM is easy, but diagnosing a case of pulmonary mucormycosis may not be that easy. Now, when and how to suspect COVID-associated mucormycosis? So it could be any patient with COVID-19 illness, active, recovering, or post-discharge. The most important aspect is that compared to COVID-associated pulmonary aspergillosis, this COVID-associated mucormycosis can occur even in patients with, say, mild COVID-19. So some of them may not be aware of the diagnosis of COVID-19. That is a very, very, very important aspect. Usually this kappa will occur only in patients who require oxygen therapy like that, but that does not apply to the COVID-associated mucormycosis. The commonest presentation of rhino-orbitocerebral mucormycosis, or the ROCM, is the nasal blockade or congestion. Then you have the nasal discharge, which could be bloody, brownish, or blackish discharge, presence of local pain, the facial pain, numbness or swelling, the headache, orbital pain, then the loosening of the teeth, jaw involvement, and toothache. And depending on the extension into the orbit as well as into the in the cavernous sinus or superior orbital fissure, you can have this blurred or double vision, or amaurosis, that is the loss of vision, paresthesia, thrombosis and necrosis, etc. And coming to the pulmonary mucormycosis, the classical clinical presentation could be fever, cough, and chest pain, and with pleural effusion, hemoptysis, worsening of respiratory symptoms. And the lung CT findings, which might help us in suspecting mucormycosis, is the presence of a thick-walled cavity. For any patient who has been having COVID-19, so maybe in the second or third week, is complaining of fever and chest pain and hemoptysis, and X-ray showing a cavitatory lesion, you're taking a CT which is suggestive a thick-walled lung cavity. So the DDs you need to consider at that time probably could be, if it is not a bacterial infection like, say, Klebsiella or Pseudomonas or Staph aureus, it could be a kappa, COVID-associated pulmonary aspergillosis. It could be a mucormycosis, or it could be a reactivation of TB. So reactivation of TB is actually very easy to to rule out. Then there are certain radiological features which favor the diagnosis of mucormycosis. It's the presence of a reverse halo sign, presence of more than 10 nodules. Usually in kappa, if the nodules are there, it will be less than 10 nodules, and the presence of a pleural effusion. So basically, this atoll sign, the reverse halo sign, is usually not present in Aspergillosis. And there are certain radiological features which might help in the diagnosis of which makes the diagnosis of kappa, that's COVID-associated pulmonary aspergillosis, more likely than the diagnosis of mucormycosis. That is the presence of a tracheobronchial involvement. That is, if there is a bronchial thickening in the CT, if there is tracheobronchial involvement, if there is peribronchial collection or tree-inbuilt nodules, it is more in favor of aspergillosis than COVID-associated mucormycosis. Why we are relying more on this, the radiological signs for diagnosis of mucormycosis and kappa is because we don't know when we will discuss in the diagnostic part. So we ideally require a CT guided biopsy or a BAL and go for the culture, etc. Go for the galactoman and to rule out, say, kappa and all. But then in our ICU scenarios, these things, in the current scenario, we are having our ICUs are flooded with patients. So to go for a BAL or a mini BAL or go for a CT guided biopsy to diagnose the etiology of a cavitatory lesion may not be possible. So it is in this juncture that we need to look very closely at the radiological signs and to make some sort of a differentials based on the radiological appearance. And you can do the serum and BAL galactomannan and beta-D-glucan test. Usually this galactomannan is fairly specific for diagnosis of invasive aspergillosis, and beta-D-glucan is actually a pan-fungal cell wall marker. But mind you, both these tests will be negative in mucormycosis. So if these tests are negative, then you can actually think away from aspergillosis and you can think in terms of mucormycosis. Having said that, there are certain situations where you can have a false positive galactomannan. That is, if you're using generic piperacillin tazobactam or ampicillin sulbactam. So in such scenarios, you can have a false positive galactomannan. We should keep that in mind. And these are the warning symptoms and signs in a patient who has recovered from COVID-19 or is having COVID-19 to make us suspect of rhino-orbitocerebral mucormycosis. So the presence of nasal stuffiness, foul smell, epistaxis, a nasal discharge which is purulent, blood tinged or black, the presence of nasal erythema, the presence of eyelid or periocular or facial edema. So you can see the eyelid or periocular facial discoloration, the pain in the orbit, sinus, dental pain, facial pain, worsening of headache, proptosis, loss of vision, paresthesia, anesthesia of the face, ptosis, ocular motility restriction, presence of facial palsy, fever, alteration of sensorium, paralysis, seizures, etc. So if there is the presence of this alteration of sensorium, seizures and all, what we need to think is that it has extended from the cavernous sinus and there is a cerebral involvement. So this IFA can actually block the blood vessels and you can have stroke syndromes and can also lead to meningitis as well. So, and why this is occurring in COVID-19? Why the patients with COVID-19 the second and third week are prone for development of invasive fungal infections, including mucormycosis. So if you look at the pathogenesis, you can see that the hallmark in the second week onwards in severe COVID-19 is the dysregulated innate immune response, the ciliary dysfunction, the cytokine storm, the thromboinflammation, the microvascular coagulation, and importantly, the last stage, that is immune exhaustion, or what we call as the immune paralysis. And this is actually the features which if a patient gets admitted in the ICU, a critically ill with COVID-19, the features which can promote the development of an invasive fungal infection. So you know that in the ICU, there is a more likelihood of developing invasive procedures. So you will do invasive procedures, and if you are not adopting the proper IPC measures, there is always a chance of introducing a fungal infection. The patients will be on CRRT, maybe on ECMO, maybe on mechanical ventilation, and we know the bane of the COVID-19 pandemic is the poor nursing ratios. That's not something which is restricted to us. Across the globe, the issue has been the doctor as well as the nursing ratio. We have more and more patients in the ICU. So then when the nursing ratio is poor, that is the patient to nurse ratio is poor, you know that the IPC takes a hit, and there is always a risk of development of invasive fungal infections as well as bacterial superinfection. So breach in IPCs are the norm in the ICUs that we know. And the use of steroids, so you know that the stipulated dose of steroids are not being stick to in many situations. We are using higher dose of steroids. So whatever be the dose of steroids, actually the endpoint is that there has to be glycemic control. We are using tocilizumab, which is an IL-6 antagonist, and now we are having the JAK1, 2, and 3 inhibitors. That is the baricitinib as well as the tofacitinib in the market. So all these together actually might create an environment which favors the development of invasive fungal infection. On top, to top that, there is an increased spore count in the ICU. Increased spore count means, usually in the ICU scenario, we are supposed to do the spore count, especially if there is an outbreak of Aspergillosis or something like that. So probably in this scenario, it might be the prudent to have a look at the spore count to see whether there is a fungal overload in our ICUs. And what exactly is the problem with dysglycemia and why it actually favors the development of mucormycosis? When the RBS, when the blood sugar is more than 200 milligram, so we know that there is an increased expression of the endothelial receptors, so glucose regulated protein 78. When there is increased expression, what happens is that if there is a mucor, hyphae can attach to the endothelium and can lead to proliferation as well as invasion. And this can lead to a neutrophil dysfunction, impaired chemotaxis, defective intracellular killing, and can lead to an increased susceptibility to fungal infection. Likely, the steroids, the use of steroids can impair neutrophil migration, the neutrophil ingestion, as well as the phagolysosomal fusion. So together, so with dysglycemia along with the use of immunosuppressants, actually fosters an adequate environment for development of invasive fungal infection, including mucormycosis. And this is actually very important, and we have discussed about the role of the acidosis, that is diabetic ketoacidosis. So when there is acidosis, there is increase in free iron. So the mucor actually using this iron permeases or the sideropores can take this free iron, can multiply rapidly, the hyphae can proliferate rapidly, and that is the reason why in diabetic ketoacidosis, usually you are having a disseminated mucormycosis, and the outcome is actually pretty poor. And now coming to how to diagnose mucormycosis. So mucormycosis is a medical emergency even when clinically suspected. So this is important because sometimes if you are looking at the microbiology or the pathology to confirm the diagnosis of mucormycosis, you may be pretty late, especially in the scenario like a diabetic ketoacidosis patient presenting with the pictures that I have shown you. So if you are seeing a black crust-like thing, definitely in the current situation in an immunocompromised host, you need to suspect mucormycosis and start empirical treatment at the earliest. You may not get time to confirm the diagnosis and to treat the patient. So that is very, very important. And all the suspected patients should undergo an appropriate radio imaging study. If you're suspecting ROCM, an MRI PNS with brain contrast for ROCM, or you can go with the CT PNS with orbital cuts. And if you're suspecting pulmonary mucormycosis, you go with the plain Ct thorax. And how are you going to get the specimen? So you need to, so basically the treatment of the mucormycosis is actually a team effort. You require the physician, you require the help of an ID physician, you have access to one, you require ENT, you require ophthalmology, you have neurosurgery, you have the neurologist, you have the microbiologist, as well as the pathologist, because it is sort of a team effort. You have to do endoscopy at the earliest, debride the tissue, and the tissue has to be sent in sterile saline for microscopy examination and formalin for histopathology. Very important. If you're thinking in terms of a pulmonary mucormycosis, ideally, you do a BAL or a mini BAL or non-bronchoscopic lavage or a transbronchial biopsy or a CT-guided biopsy and send for microbiology as well as culture, microbiology as well as pathological examination. And you look at the X-ray test and HRCT appearance we have discussed, and you can send markers. You don't know it is mucormycosis. It could be a kappa as well. So you have to send the markers like galactomannan as well as beta-D-glucan. And these are the signs on Ct thorax, which might give a clue towards the diagnosis of mucormycosis. So one is the classical halo sign. Halo sign is, you can see a nodular infiltrate surrounded by a ground glassing. This halo sign is actually classically seen in Aspergillosis. In neutropenic individuals, usually you are going to see this halo sign and you take it as an evidence of angioinvasive Aspergillosis. You can get this halo sign in mucormycosis also. But the sign which is classical of mucormycosis is presence of a reverse or an inverse halo sign, which is otherwise referred to as the atoll sign. Here you are having a ground glassing which is surrounded by a rim of a nodular lesions. That is important thing. And this is the atoll sign or the reverse halo sign. And then you know that the mucormycosis, it's a very lethal, it is a rapidly multiplying hyphae are there, it leads to angioinvasion. It can actually block the the vessels. So if there is a vessel which is going on to a lesion, and if there is a vascular occlusion on CT angiogram, you can think in terms of a mucormycosis. And if you are taking a MRI of the lung, which is highly unlikely, then there is a something sign known as a hypodense sign. And another aspect is that in the CT, if there is evidence of contiguous spread, that is from a mass lesion or a consolidation, if you think that there is an invasion into the say pleura or into the diaphragm, chest wall, spleen, etc. So that is the tissue planes are not obeyed. Thinking in terms of mucormycosis, aspergillosis is not that aggressive in its invasion. So if such a thing is there in the CT, think in terms of a pulmonary mucormycosis, and that rapidly progressive lesion in the lung lesion, a nodular cavitating lesion which is rapidly progressive. So you can see on day 1, day 3, as a day 8, and day 15. So it's a rapidly progressing necrotic pneumonia-like lesion. Think in terms of pulmonary mucormycosis in the right host. Then, from from staining, from culture, how are you going to diagnose mucormycosis? So important aspect is that, so the first one is the silver staining or the GMS staining, pulmonary methylamine silver staining. You can see this is an aseptate, it's a broad aseptate or a posiseptate hyphae there. It's the classical hallmark is actually the presence of a broad aseptate or a posiseptate hyphae. In contrast to that, in kappa, you are going to see a slender hyphae. So the first one is a ribbon-like broad hyphae. This is a slender hyphae with a dichotomous branching. So if you are seeing a broad aseptate hyphae, think in terms of mucormycosis. And one important aspect is that, we are with the current, I don't think any of the medical colleges or any institute in Kerala is capable of, looking at the speciation as well as the sensitivity. So which drug is sensitive against this particular strain of Mucour and all is not possible to do here. So that is why we have a usual diagnose, a therapeutic approach is, once you diagnose this aseptate hyphae, you just start the patient on amphotericin. Even without diagnosis, if if the patient is fitting in with that of ROCMO, you definitely start the patient right away on amphotericin. Now coming to the treatment of COVID-associated mucormycosis, as discussed, it is a team effort. The most important aspect is the control of diabetes and diabetic ketoacidosis. We don't want an acidic environment. We don't want the fungus access. We need to cut off the access to free iron. That is very, very important. So we need to control diabetes. We need to take care of diabetic ketoacidosis. If the patient is on steroids, we need to discontinue the steroids rapidly. And if the patient is on other immunomodulating drugs like say baricitinib or tafasitinib, we need to discontinue those drugs pretty rapidly. And the most important aspect is aggressive surgical debridement. So with amphotericin alone, you are not going to save the patient. You need the help of the ENT surgeon. You require the help of the ophthalmologist. Aggressive debridement is essential because it is a necrotic lesion. So in necrotic tissue means it's a devitalized tissue. So the amphotericin is not going to reach the tissue at all. So without extensive or aggressive debridement, your drugs are not going to reach the site where it is supposed to reach. So extensive debridement, you have to remove all the necrotic material. If the eye is involved, get the opinion of ophthalmologist, and probably you may have to do excimeration of the eye. And in pulmonary mucormycosis, if it is confined to a lobe and if it is not responding to treatment, you may have to think about lobectomy even. And we know that the treatment, that is administration of amphotericin B, is not a joke. So we need to give that drug for say weeks or sometimes months together. So ideally it will be better if you are putting in a PICC line or a center line. And most important aspect is that this amphotericin, whether it is liposomal or say amphotericin deoxycholate, they are nephrotoxic. So effect-wise, so we do have experience using amphotericin B deoxycholate over the last 10 years or so, and we don't have much problem with the conventional amphotericin. Patients will be able to afford that. But you should keep one thing in mind: the nephrotoxicity of this conventional amphotericin is actually around 6 times more than that of liposomal amphotericin. So if you are using conventional amphotericin, every day you need to monitor the creatinine levels, the potassium levels, as well as the magnesium levels. So what we usually do is, if you are giving conventional amphotericin to negate the risk of development of nephrotoxicity, you preload the patient with 1 liter of NS, then give amphotericin B deoxycholate, this 50 milligrams in 500 ml of 5% dextrose at the rate of 0.08 mg per kg per hour. Okay, so and that is over 6 to 8 hours, and it's a slow infusion. After that, also you postload the patient with 1 liter of normal saline. So by preloading and postloading the patient with normal saline, you can sort of bring down the nephrotoxicity. If you are using the liposomal amphotericin B, which is by with all the guidelines recommend liposomal amphotericin B, And conventional amphotericin B should be used only if you don't have access to liposomal amphotericin. If the patient can't afford that, that is going to be the situation as far as majority of the patients are concerned. And if there is means any other contraindication, only then you should be using amphotericin B deoxycholate. The dose of liposomal amphotericin is ideally 5 to 10 mg per kg. If there is a CNS involvement, go with 10 mg per kg. Dilute it in 200 ml of 5% dextrose and infuse over 2 to 3 hours. And definitely monitor the creatinine as well as the potassium every day. Every day you have to monitor it, because the tubular toxicity is going to occur means after some time. So you need to monitor it every day. So usually the mistake that we majority of the residents do is initially they will monitor say for 1 week or say 2 weeks, and after that they forget about it. Actually, as the days progress, you need to be more careful when you are administering amphotericin B. And if the patients are intolerant to amphotericin B, we do have the salvage treatment with drugs, posaconazole, isoconazole. Posaconazole is available in the syrup form, the intravenous form, as well as the tablet form. And the isoconazole is also available in the intravenous as well as the tablet form. So posaconazole, the tablet, the dose will be 300 milligram BD on day 1, followed by 300 milligram OD. And the difference between posa and isoconazole is that posaconazole, the propensity for drug interactions is pretty high. So if you do have access to TDM, therapeutic drug monitoring, you need to look at the trough level after 7 days. And we do have the nearest center which can do the posa trough levels for us is CMC Vellore. So if you do have access to isoconazole, definitely prefer it over posaconazole. And the dose for is 200 milligram TID for 2 days, followed by 200 milligram once a day. And intravenous isoconazole 200 milligram will cost around say 10,000 rupees per day. And how will you monitor the response? One is clinically, microbiologically, you can monitor the response, and you can also take the imaging at periodic intervals to see the resolution. And the duration of treatment has to be individualized. You cannot say that you need to give 3 to 6 weeks of amphotericin B, etc. What we do is give the maximum tolerable dose of amphotericin B, and then switch over to posa or isoconazole. And the maintenance phase is going to be for around 3 to 6 months based on the radiological resolution as well as the clinical response. This is actually from a recent editorial in the Indian Journal of Ophthalmology. That is the management approach for a possible, probable, and proven rhino-orbitocerebral mucormycosis. So basically, the possible ROCM means in the right patient, a patient who has had COVID-19, history of diabetes, uncontrolled blood sugars, patient has been on steroids, and then if the patient is presenting with, say, a bloody discharge from the nose, etc. But you are doing a sinus endoscopy, you are not finding anything. The CT is not suggestive. That is the possible ROCM. Here, what they advise is to keep the patient under follow-up, and if needed, repeat the endoscopy after say 2 days or so, after 48 hours or so, and repeat the imaging if needed. So basically, there is no indication to start amphotericin B here. Okay, just keep the patient under follow-up. The next category is the probable ROCM. So probable ROCM, majority of our patients are going to fall into the category of probable ROCM. So proven means you are having a microbiological or a histopathological evidence of mucor. Okay, so in 50% of cases you may not have that. So probable ROCM means in the right patient, there is a uncontrolled diabetic patient who has had COVID-19, or any patient who has exposure to steroids or other immunomodulators is presenting with the classical features of ROCM, and you are taking a CT which is suggestive of an invasive fungal infection, or doing an endoscopy, sinus endoscopy, and you are seeing a black crust, but you are not able to prove it microbiologically or by histopathology, that is a probable ROCM. This patient merits treatment with amphotericin B. That's the most important thing. You do not wait for this confirmation. With this patient, you have a multidisciplinary discussion and initiate the patient on amphotericin B at the earliest. And then the most important aspect is that from the sinus, it can spread into the orbit. And the important aspect is that once it gets into the eye, the amphotericin B is not having that much of penetration into the eye. So the ophthalmologist might prefer, intravitreal injection of amphotericin B, 3.5 milligram per ml. And the ENT surgeon also might consider irrigating the sinus with 1 milligram per ml of amphotericin B. So this is the most important aspect. And sometimes we know that aggressive debridement is necessary if the eye is, if the eye is totally involved. If you are not removing the eyeball, it can act as a nidus, and the infection can spread into the brain. So the ophthalmologist will have to decide on the need for excideration. This is one of our patients with cutaneous mucormycosis. You can see the black, the black tissue, the patient requires extensive debridement. So any patient presenting in such a lesion, think about cutaneous mucormycosis. Now, another important aspect is we are all familiar with the diagnosis of COVID-associated pulmonary aspergillosis. So any patient in the ICU, any patient who has been requiring oxygen, so patient is not improving, hypoxemia is not improving, you are taking a CT, there is a nodular cavitating lesion. So it could be kappa, it could be TB, or it could be Mucour. So any patient who has received steroids or tocilizumab, we need to think of all these diagnoses. Okay, so TB can be ruled out by the right test. Then kappa versus Mucour. So we have discussed about the radiological aspect, how it helps to differentiate between the two. If you do have access to BAL, probably a BAL galactomannan will help us in differentiating between the two. And all the cases are not ROCM. Yesterday, the State Medical Board received a mail from one of the hospitals saying that a patient with a nodular cavitating lesion, they did a BAL, and the BAL is growing in Mucour. So we are also having pulmonary mucormycosis in Kerala, and we need to be on the lookout for that. The most important aspect is that treating Mucour, it requires a bit of an experience because amphotericin B is a very toxic drug. So you need to monitor the patient routinely, and probably looking at the state of affairs in other states, we may not be having access to the antifungal drugs also in the near future. So the most important thing that we should be aiming at doing, what we should be educating our patients to do, is to eliminate the risk factors for mucormycosis. Okay, so COVID, I don't think per se is the reason for development of mucormycosis. COVID is actually a setting. COVID-19 is a setting. And in this setting, an uncontrolled diabetes, due to, you can have a poor control of diabetes because some of the patients are not having access to this glucometer strips and all. And then, dietary control may be pretty poor. You are using drugs like steroids, which can drive up the blood sugar levels and all. So basically, the poorly controlled diabetes is the major issue. Good glycemic control during management of COVID-19 patients is pretty required. It's not very easy, that we know. Systemic steroids should only be used in patients with hypoxemia, or as far as the state protocol is concerned, those with exertional desaturation. Other patients should not be started on steroids. Universal masking might help because you need to inhale the sporangiospores, and universal masking and avoidance of construction sites, especially diabetics and all. It will be better to avoid the construction sites and all, or wear mask at all points of time. During discharge, the patient should be advised about the early symptoms or signs of mucormycosis, like say facial pain, nasal blockage, excessive discharge, loosening of teeth, chest pain, respiratory insertions, etc. So this is actually going to be a problem because we know that we are having, say, lakhs of patients with COVID-19, but number of cases of mucormycosis is actually pretty low. And how to word this thing. So it will be more prudent for us to say that you need to control your diabetes properly. And then we need to identify a subset of patients with uncontrolled diabetes mellitus and need to educate them about the warning signs of Mucour and when they should return back to us. And these are certain aspects because why in India we are having more cases of mucormycosis in certain geographical terrains we are not very sure about. Because it is not really related to oxygen therapy, because even following mild Mucour, also mild COVID-19, also we are having patients with COVID-associated mucormycosis. Having said that, all the 7 cases in medical college, as of now, we are having 3 admitted patients. Of the initial cohort, 3 of them were from Tamil Nadu. None of the patients had ended up in ICU. All of them were diabetics, and they had received steroids, high dose of steroids, and the patients in Tamil Nadu did receive 10 times the stipulated dose of steroids. But none of them had, exposure to oxygen. But, looking at Gujarat, etc., when one hospital is taking care of more than 150 patients, there has been suggestions that industrial oxygen might be the culprit and all those things. So what we can do is, when we are using humidifier bottles during oxygen therapy, we need to implement strict IPC measures with regard to the use of humidifier bottles, which are used during oxygen therapy. We should be using sterile water. In certain ICUs and certain wards, the habit is about using boiled tap water. So into the humidifier bottle, we should be using sterile water only. And it must be, only sterile water must be used in humidifier bottles, and the water in the humidifier bottles should be changed daily. And the bottles itself should be changed once in a week for the same patient and in between patients. And the bottles must be cleaned with mild detergent and hot water using a small brush, and must be sterilized according to manufacturer's instructions. So if it can withstand autoclaving, go for autoclaving. Or else you use the Sidex or 2% glutaraldehyde, and the immersion time is 4 hours. And then wash the bottle with sterile water. After sterilizing these bottles, it must be dried and stored properly. And we should have someone to see whether these things are done properly. And as part of the guidelines, the state medical board did say that in all the ICUs in Kerala, it will be right to look at the fungal spore count to have an idea about what is happening in the ICUs. Usually what we are expecting is the increased spore count with reference to Aspergillus. Okay. This is actually, now we are having 2 patients. We are not put into that. We had around 5 patients over the last 6 months. You can see the pictures, suggestive of ROCM. You can see the palatal, the black crust in the palate, hard palate. And these are the endoscopic findings thanks to our ENT department. You can see the crust. And 3 of them were rhino orbital, this thing, and 2 of them did extend into the brain. You can see the images from the sinus, it is extending into the orbit, and from there into the brain. So this the debrided tissue, which is sent for microbiology, microscopy, as well as histopathology examination. You can see the black crust. And this is another interesting scenario, because yesterday we got a mail from one medical college saying that compared to 2019, in last year they had 5 times increased number of cases of mucormycosis associated with diabetes. Okay. Usually that department used to see around 2 cases per year. Last year they saw 10 cases, but then they were not able to find an association with COVID-19 because the antibody tests were not done. So it need not be a concomitant COVID-19 infection. It can occur following a mild COVID-19 which the patient may not be aware of. This is actually very, very important. Kappa will occur only in case of a moderate or severe COVID-19, whereas mucormycosis can occur even in patients with a mild COVID-19 which the patient might not be aware of, may not be diagnosed also. This lady is a 49-year-old female without any apparent comorbidities except history of anaphylaxis to multiple drugs. There is no history of diabetes also. She had, it's not severe pneumonia. She gave history of a lower respiratory infection 3 months back, person with headache and epistaxis. And you can see the CT, there was some sort of an evidence of a previous viral bronchopneumonia. And a COVID antibody test was done, which was positive. So probably what she had 3 months back was a mild COVID-19 infection. And then, she presented with features of sinusitis, and the DNA was done. You can see that the patient is having a crust and had extension into the skull base as well. And this patient was treated with liposomal amphotericin B followed by isavuconazole. So this is a very, very important. That is, the majority of the patients may not be aware of the diagnosis of COVID-19. So any patient in any okay, sorry, some problems with my connection. So what I'm trying to convey here is that hospital had seen 5 times the number of cases of mucormycosis over the last, say, 12 months compared to their previous background rate, which was only, say, 2 per year. Now they saw around 10 per year. And then they could not make an association with mucormycosis in the history of this. They could not make an association with COVID-19, probably because the patients were not aware of the diagnosis of COVID-19. That also we need to keep in mind, but does not change the, the prognosis of the patient in any way. So what I'm trying to convey is that the most important factor here appears to be the glycemia. So patients, if they're having very good glycemic control and if you're using the steroids in the right dosage, they should not be at risk of increased incidence of mucormycosis. And these are certain misinformation. One is mucorales are not black fungi. Black fungi are different category of fungi having melanin in the cell wall. That is a phylophthora group. So it's not contagious. It does not spread from one person to another. The next aspect is actually taken from the European group. They say that it's not spread by oxygenation, not spread through the humidifier and water usually. The fungi remain in the indoor and outdoor environment. The spores enter the respiratory tract via the air. So this is actually the classical teaching. There, one assumption is there. That is, we are cleaning this humidifier and all those things. We are sticking on to the standard IPC practices. If that is the case, then it won't spread through your oxygenation, humidifier, and the water that we are using. But unfortunately, COVID-19 is characterized by compromised infection prevention control methods because of many reasons. So we need to be looking at our humidifier, the oxygen that we are using, and all those stuff, especially in industrial oxygen. So we never thought that we would have to rely on industrial oxygen and all those things. So that aspect is also being looked at in other states. And the next aspect is, should we be using any sort of antifungal prophylaxis? This is very, very important. because we do have access to isavuconazole tablet as well as posaconazole syrup as well as posaconazole tablet. So any patient who is having severe COVID-19, either has received tocilizumab or steroids and their blood sugars have been very difficult to manage, will putting them on say posaconazole or isavuconazole prevent, like in the setting of a hematopoietic stem cell transplant where we put them on posaconazole to prevent the development of invasive aspergillosis. Will it work, or is that strategy justified in the setting of severe COVID-19? But actually, the studies have shown that still the incidence of COVID-associated mucormycosis is actually pretty rare. So if in any particular cohort, if the incidence is more than 10%, it is only when we should consider a drug for prophylaxis. So as of now, there is no role for antifungal prophylaxis. Having said that, we should keep one thing in mind. We are seeing a patient in the second or third week, we are seeing a nodular cavitating lesion. And we are thinking that it is, say, COVID-associated aspergillosis. And if you are starting the patient on oriconazole, herein lies a problem because oriconazole is a drug of choice for aspergillosis. But then oriconazole has a property of actually selecting out of mucor or maybe stimulating the growth of mucor because it did not inhibit mucor. So the thing is that any nodular cavitating lesion need not be aspergillus. It could be mucor as well, and we need to keep that in mind. So thank you very much for patient listening.